I think our culture in our workplace can sometimes really impact our ability to be able to be authentic in responding to our own personal grief. Acknowledge that this is going to be a reoccurring theme, that this isn't something as a one and done, that this is a process that you're going to continue to revisit. And in recognizing that, I think this allows us to be more proactive and responsive to this emotional part of our job.
You're listening to the Oncology Nursing Podcast, where ONS Voices Talk Cancer, a resource from the Oncology Nursing Society. Through conversations with subject matter experts, we examine the important issues in oncology nursing, from new treatments to patient-centered research to advancements in clinical practice. Join us as we hear from nurses in all facets of oncology care, from bench to bedside and everywhere in between. Welcome to the Oncology Nursing Podcast. Hello, and welcome to the Oncology Nursing Podcast. I'm your host, Jaime Weimer, Oncology Clinical Specialist at ONS, and today we're talking with Carla Jolley, Palliative Care Advanced Practice Nurse and Coordinator for the Palliative Care Consult Service embedded within the Oncology program at the Whidbey Health Medical Center in Coupeville, Washington, about how oncology nurses can approach and manage the grief they face as an innate part of their work. You can earn free NCPD contact hours after listening to this episode and completing the evaluation we've linked in the episode notes. Thanks so much for joining us today, Carla.
Oh, thank you so much for having me. I'm really looking forward to this.
So to start things off today, can you briefly define grief and how it affects oncology nurses?
Yeah. So when I think about grief, it really is about an emotional response to loss, and it can have many dimensions. And when we think about ourselves as oncology nurses or nurses as a whole, we are often exposed to a lot of suffering and also loss in our workplace. But I'd like to bring it back that we can also experience loss in our personal lives. None of us are immune from tragedy. We can re-experience a loss. Like I had a patient the other day who looked a lot like my mother, and I just really felt this connection to her. And, she has serious illness and stage 4 disease. And I was thinking a little bit ahead of what her journey was going to be like, because my own mother's journey was with stage 4 breast cancer. Sometimes the work that we do can bring up kind of our reflection on personal loss that we've had in the past. Then we also need to sometimes think about sometimes when we're experiencing just loss of immediate kind, like if we have a loss of a coworker, how that might be impacting our work. So then I think about oncology nurses' experiences losses when they have patients who die that they've cared for either brief periods, which can be difficult because we have this reflection or connection with patients and they've moved through that illness trajectory very quickly. And so feeling kind of this loss, particularly reflected in that relationship most often with the family, and how do we respond to that? And I think the thing that I've seen impacted the oncology nurses in our clinic the most is when they've had those long-term relationships where they've seen the patients through that trajectory that may not only expand over a few months, but maybe even over a few years. And when we think about those patients, particularly like with blood cancers that we're seeing on a day-to-day, sometimes basis when they're receiving blood products. So many hours to spend with patients and families. And when we think about some of the different kinds of losses, we can also be experiencing grief for that anticipatory loss for patients, knowing that they're coming to the end of their disease process. And particularly when we think about that transition to hospice, because often at that point, then we lose touch with those patients as they move on to another interdisciplinary team. And the last piece when I think about oncology nurses and grief is that they can also experience secondary trauma. And that results from the suffering of another, because it's a shared trauma. We're watching them go through their grief process, anticipating the loss of their loved one, and witnessing patients and families suffering.
That's really a compelling and complex landscape that oncologists work in. As you mentioned, the different ways they interact with their patients, the frequency they see them, how well they get to know them. Sometimes our interactions are brief because of a rapid decline. And so there's a very diverse landscape in terms of how that grief can present itself. You've hinted at this a little bit already, but what are the different types of grief, and when might oncology nurses experience this throughout their careers?
When we think about general grief, it includes multiple responses. So that includes that emotional response how we feel about those patients, the cognitive response, how we can get kind of spinning about them, thinking about them, maybe beyond our workday. Sometimes it's physical responses that we just literally feel sick to our stomach, very sad, maybe depressed feelings in there, which can result in poor sleep or perseverating about that patient and their family. And then behavioral. Sometimes I think when something is too hard, we may even try and avoid experiencing that grief. So maybe choosing not to take care of that patient that day, or being more, centered, and putting it more compartmentalized. There's the second kind of grief I think of is this anticipatory grief. And I touched on that briefly when I talked about what oncology nurses experience as far as in their day-to-day. But when we think about the definition, it's really that normal mourning. So it is normal. We need to normalize that not only for ourselves, but also for our patients and families. And this occurs when we know that death is expected. Complicated grief, these are things that most often I think more of that when in identifying that and maybe patients that our families that we've taken care of. And that's when the feelings of loss are so debilitating and don't improve after a long period of time. So I was thinking of a little guy who was married for like 70 years to his wife. And that is a long time. There's no end point in that grief, of course, for sure, but was just not able after a year and a half to resume his normal functioning or life. And we were seeing him kind of starting to deteriorate, which is not unusual. There's a lot of physical components that come when, especially patients who have an advanced stage, experience a significant loss. But he was still kind of showing up at the clinic. Does that make sense? Just kind of checking in. And so kind of identifying after a period of time, that maybe we had already kind of sent him off to the bereavement program as far as a resource, but recognizing that really was up and beyond, and how could we best help him? When I think about the other one is the disenfranchised grief, which is grief that's not openly acknowledged or socially validated or publicly observed. And these are people who are ourselves that maybe in our personal lives that we have grief over losses, or people that have died that maybe are not acknowledged as a sanctioned relationship to grieve about. So maybe an ex-husband, an ex-in-law. I think sometimes is even a perception sometimes that oncology nurses should be more compartmentalized and not so invested in a loss of a patient. And then cumulative grief. This is, I think, where we need to be careful as professionals. And that is that we experience on a day-to-day basis all these kinds of different grief, except complicated grief, and the anticipatory grief, the loss of patients, the witnessing of suffering and loss. And if we don't take time, and we'll talk about that further into the podcast, to process some of that, it starts to accumulate. And that is, I think, the message that we're trying to talk about today is what to do about that as things kind of build up and those losses. We continue to collect those losses in our personal lives.
As I listen to you talk, I think all oncology nurses are accustomed to the response of like, oh, where do you work? Oh, I work in oncology. Oh, that must be so sad. And then we're quick to be like, oh, no. It's, yes, it's sad, but, and then we try to emphasize, well, there's all these great relationships and we get to know these patients and take them through this journey. And all of that is true. But I think sometimes we're afraid to sit with the part that is sad and just like sit with those feelings and allow it to be and acknowledge that, it is tough sometimes. Not all the time, thankfully, but parts of it are really tough. And so, like you said, we're going to get more into that. But I think we're always quick to try to defend it. Like, no, it's not sad. And that is true, but it's okay for it to also be sad sometimes. And how we approach those feelings that we experience and the grief that we might experience, it's important to acknowledge and sit with those feelings as well.
I definitely agree, Jamie.
So let's talk about how can oncology nurses maybe perform a self-assessment to maybe identify their own grief and hopefully set themselves on a path to managing that grief. What are their assessments that they can do?
I really encourage what I call a personal loss history, because we can kind of identify sometimes that, yes, I lost my mother when I was 40 years old, or my grandma when I was 13, or this last year I lost my dog, and that can be really impactful. But, really looking at where my own kind of losses have happened in life, whether that's mapping out people who have passed on that we've cared for and loved that have had a lot of meaning to us, what kind of changes or transitions in our own lives, divorces, separations, children leaving home, empty nesters. I mean, there's a lot of loss that happens on a day-to-day basis. And so kind of thinking of just about who we are in the accumulation of our own personal losses, because I think sometimes where it gets triggered in that kind of secondary trauma is when we see ourselves in other people's situations. And then I think we are all unique in how we grieve or how we see different situations or how we have different relationships with different patients. And so what is our role of our own cultural beliefs? I mean, was your family very demonstrative, or did they always kind of, tuck things down? I mean, what have been your models of other people and how they've grieved, and what have you taken into that as part of your own culture and response? And then your spiritual beliefs. What is it that you believe about in the world of that spiritual journey? And is that something that you use as comfort in your day-to-day work as well? I think it is also important to realize, like I said, I'm an old soul as far as in my personal work history is, what has been your own personal work history? Some people have worked in the ED. That's a lot of traumatic loss. I mean, did you work on an oncology floor, like on a bone marrow transplant unit, where some of that cumulative kind of more, I want to say, adrenaline loss, where there's lots of serious things going on day to day? Did you work maybe as a CNA in a nursing home and you have this affinity to, and your experience has been with people with advanced age and loss? And where are you at in your career? I mean, if you're new in your career, I see these, this is so funny for myself. I see these young oncology nurses and I see myself there, talk about a little countertransference, just looking at them as they, they're so excited about this new job. And then, as you see them lose more and more patients and kind of like, wow, this is a little hard, pulling up your bootstraps and keep on going. And they've created these relationships. Whereas, I see the older nurses that I've worked with for decades. Like I said, I've been here for a while, and just see how they kind of take care and mentor those younger nurses, and not compartmentalizing, but kind of giving them permission and time out to take care of some of those more fresh feelings that can sometimes happen. It was really interesting. We had a conversation the other day about, what do we do when a patient gets bad news and they're not coming back for treatment? Treatment's not an option anymore, and they're literally walking out the door for the last time. How do we, as a team, or how do we get that information so we can respond and say goodbye? It's kind of that trajectory through our work trajectory that we need to think about where we might be wanting to build our skills and support around that. And then, this whole thing, which is I'm always learning, how good or challenged are you with boundaries? And there's always going to be patients and situations that are going to tug at your heart. And that doesn't make you bad with boundaries. But if you're going home and always taking it all in and can't separate your work life from your personal life, then there's a place to start thinking about that as far as that assessment. Is there something I can do for myself to make this not so difficult? Because that's, of course, leads to burnout and compassion fatigue. Ending on a positive note, where do you draw your own personal resources and coping mechanisms? What's your strength and your support? Is that lovely old soul that is your mentor on the oncology unit, and she's a go-to person, and you have made it like this, not secret pact, but a pact, that's somebody who you can talk to when things get kind of overwhelming or share losses? Or, do you have a pet therapy? Is there a dog you go home to and you just bury your head in and you just cry and let go that way? So what is it in your life that you can be proud of that you use to take care of yourself to counterbalance some of this cumulative loss?
I don't even know where to start with all of that. There's so many good things that I want to, what I think of as you responded to that question is, I think, how are we setting up our new nurses, whether they're new to oncology or brand new out of school? I mean, we know with the vacancies we're seeing and the staffing, like we are happy and welcoming of any job we can fill. But it's like, how do we not only identify the right person to be able to be prepared for this type of grief and loss that they're likely to experience in oncology? How do we prepare them? What are the right questions to ask? And like you just mentioned, like, how are we evaluating what is their support system? What is their method of managing that? All of that probably needs to be part of that interview process, not to scare them away, right? But to prepare them so that they can think about, like, this isn't the whole job, but it's definitely a part of the job that can make it not a long-standing employment if it's really something that people struggle with. And I also like how you mentioned it is a job, it's a career in oncology nursing, but we come to it with the skills that we've developed over our lifetime in terms of how we manage or don't manage
Right.
our grief. And so those are important things for whether they're asked as part of an interview, kind of behavioral assessment questions that we like to ask, or if it's just a self-assessment of just saying, like, how have I experienced grief and loss in my own life? And did that go okay? Like, how did I rebound from that? And just those are important things, I think, for us to consider whether we're welcoming new members to our team, if we're in leadership and we're actually trying to recruit members to our team. All of those things are important. It's not just the skills of memorizing side effects and administration technique, but like, how do we work through that so that we can sustain and be a productive and joyful member of that career, hopefully for life, because we like to keep people forever in oncology. So.
Absolutely. Absolutely.
Are there any other areas that nurses should reflect on to maybe to better understand and manage their own grief?
I think taking these inventories really gives you some rich places to start for sure. And maybe journal and figure out kind of what you've discovered about yourself as well. It's interesting. I had a colleague and, I met her earlier in my career and I really resonated with this. She would say, and it's okay to compartmentalize a little bit. I don't want to make that sound a negative, but she would say she has this box or this compartment in her life that she calls her nurse's pain. And that just so resonated with me because I don't know unless you work in the healthcare field that you can really understand that kind of just soulful pain that sometimes you can carry, with the witnessing of suffering for sure. And I think the social context, and this is an interesting thing to reflect on, the social context of our workplace, and getting back to Jaime, that whole thing about kind of thinking about our young nurses, is that it generally discourages us to express grief in response to that question about, that must be so sad, you work in oncology, in favor of emotionally compartmentalizing the sadness or the sad part of our job. And that we need to be absolutely strict on our boundaries and we can't let ourselves care too much and have that stoic professional identity. And I worry about that when we think about that areas, going back to the question, areas should reflect on to better understand. I think our culture in our workplace can sometimes really impact our ability to be able to be authentic in responding to our own personal grief.
That's a great comment. And I also think, and maybe I think we're going to get into this here in just a moment, but sometimes in the middle of a clinic is not the time, right? You got a busy clinic, you got 20 patients lined up for the rest of the day. And so you have to compartmentalize just because of the nature of where you are, what the rest of that day looks like. So sometimes it's out of necessity and sort of self-preservation to get through your day. But what do you do then? When do you take that time and when do you structure it so that you're giving yourself that time? So that's kind of a next question is like, what are some actions that nurses or their teams can do to respond and to encourage, whether it's individually or collectively, to cope with that grief that they experience?
I really encourage people to, create a place it could be a physical place. It could be a place in a staff meeting. It could be a place in a huddle, but create a place and a space to debrief patients that we have lost. So, a place that we can remember and acknowledge. And not only the kind of the acknowledging the naming of the names. I know a lot of teams do that, figuring out who has died. A lot of times we find out after the fact, particularly on oncology teams, because they've, moved on and hopefully have had a satisfying experience with hospice, or they may have had, certainly a tragic demise or a hospitalization. But I think coming back, and I think this is how we build ourselves up. This is why I still do the work I do. I'm still here, is because I just really reflect on those gifts and learnings from the patients and families that I care for. Thinking about people's little weird quirks, or Sammy who would bring in, molasses cookies every other week when they got their immunotherapy, or the delight, that they compliment, just the positive things that can come from the work that we do. So bringing back some of the joy and the reasons we do what we do. I think we also, though, need to say, this isn't always easy. And sometimes in our lives, so going back to that personal loss history, if you're going through your own personal loss, or if you've had a series of losses one after another, is, finding that one-on-one support. And whether you're seeking it out yourself or you are providing it as a mentor and identifying nurses who are young in the field or young to the practice. I mean, we often change specialties mid-career too. Just because you're an older nurse doesn't mean that this is something that you're familiar with, particularly in oncology. And if you're lucky, if you're in a bigger system or you have an interdisciplinary team, I cannot acknowledge enough the role of that social worker or the chaplain, because they are not only available for patients and families, they are available for staff as well. And if you find yourself in kind of a place where it's feeling like you're tipping over into burnout or into compassion fatigue, employee assistance programs, most settings have those these days. And I think we forget either to offer them up if you're finding a colleague that you think, wow, this is more than I can support or take on, or you yourself are saying, I feel like I'm tipping over. I think I could use a little bit more help, reaching out to your employee assistance program as well. I also encourage teams themselves. I think shared grief is an important way that we can really take care of ourselves. And so create a team. If there's no team, of course, a personal ritual, but create a ritual on a regular basis. So like I said, find that place of reading of the names or writing of the cards, having cards available so you can write those personal notes back to patients' families. And then maybe a memory board where you can put obituaries or cards that come in, things that people have acknowledged just the importance that you've been in their journey. And those come in and they're kind of brief and poof, they're gone. But our hospice team actually has a bulletin board where they tend to put all those up. And so, you can just remind yourself, when you feel like you're not doing a good day or having a good day, that there wasn't a good day and that, you have done good work out there. Because I think sometimes we forget all about the good work that we do. Recognizing those, of course, I think we all have a responsibility for checking in with people and recognizing those who might need extra support and creating an environment so that people can ask for help. Like going back to that kind of social context of healthcare workplace where people feel like they can't ask for help. How can we take an assessment of our own work environment? And does it feel like someone would be able to speak up? Or do you feel like it would be seen as kind of a negative? Oh, that, they're just letting it get to them, or, they don't have good boundaries, or, we can really be mean. Think about other people, it's kind of like the playground and you kind of go, wow, that's not very kind at all. So can we create a kind environment where people feel okay about saying I'm struggling?
Absolutely. And that all comes back to culture, right?
Absolutely.
The culture of the unit or a facility, even if it's just your clinic workroom or your infusion area, but just having that culture that, and again, it starts from the onboarding onward, is just creating that culture of like, this will be hard at times, everyone is encouraged and really required to understand what they need to help themselves cope. And I think you've given some great examples of collective activities or things that can be open to any staff member that wants to participate. But sometimes that's not their jam and they'll want to do something else, and that's okay too. But just emphasizing, and from the leadership perspective, making that a focus of your performance is also how you recover when you're not here. And that's important to continue to emphasize, not only that we have to take that personal responsibility to help ourselves heal, but know that there's resources out there. If what you have, the tools and the resources you have in your own personal toolbox aren't enough, that you need to feel empowered to reach out and to be vulnerable enough to say, I'm really struggling. And hopefully there's that culture, that safety net there to say, okay, well, we've got you. Here's where you can go, or here's how we can help, or let's figure it out together if we don't know what the next step is. So those are all great actions. And I just love stories of when people have patients, whether they're quirky or funny or just heartwarming. I think we all have those. And to me, that's a huge thing that lifts my spirits when, even if it was that patient that you're just like, oh man, not one more day. But, it's just, those are the memories and they're early from my career. I've been an oncology nurse for 16 years, but it's those first 3 years I remember all of those patients, and the quirky one who brought in an entire smoked salmon for Christmas. We're like, we don't would want salmon. It's the middle of the day, but thank you. Just those are the funny things where like you'll remember, and it will lift your spirit and it will remind you that there's both good and bad. So I love all of those ideas you brought forward. So we've talked a lot about nurses kind of coping with their own grief. Are there any approaches to help nurses respond when they see their patients or patient families experiencing grief?
I think this goes not only for ourselves and, our relationship with our colleagues, but is definitely, we cannot listen enough. And when people have a loss, particularly if they come back to say thank you or say goodbye, family members, just listen to their story, because it is in the telling of the story, and we may need to hear it more than once, is where some of that healing process comes. So listening to their story. And I think it's okay to acknowledge, the losses that they're having, saying, this must be really hard to think about, this may be your last treatment today. I am very sad with you, that it is okay to express your own emotions. Or I had a lovely woman with ovarian cancer call me, and she was trying to, this is the danger of online access to your records. She got her PET scan before she had her oncology appointment. And we had already been kind of talking about her next steps as far as weighing benefits and burdens if she were offered another round of chemo. And she goes, did you see my PET scan? And I just said, yes, it just feels really crappy. And I am just so sad and grieving with you. We thought this might be happening because she wasn't feeling good, but I'm so disappointed, and I'm just so sorry. Being able to just express or be in that emotional place with them, it's okay to and I think it's okay too to tear up. I mean, people, it's okay to be really sad, not that they're, of course, we always give that caution. We don't want the patients taking care of ourselves, but it's okay to deeply feel, some of the interactions that we have with patients and families, particularly when they're sharing their grief. You also need to know how to respond as far as if they are going to need some more support, because you're right, Jamie, we talked about you may have 20 patients that day. Where are we going to steer them? What brochures are we going to give them? What bereavement resources are out there? How are we going to help them kind of connect beyond just that interaction that you're having? And I think lastly, when I think about it, is just normalizing the process. So when people are feeling grief or patients are sharing grief with them, just saying, I know it doesn't feel good, but boy, it's okay to be angry about this. You've fought really hard, and, now we're saying goodbye. Or, just normalizing some of the emotions or naming the emotions that you're seeing so that they don't feel like they're crazy as far as being able to experience some of the things that they're experiencing, because, there's just such a wide range of responses physically, emotionally, and again, behaviorally that we can see or observe in our patients as well. And a lot of times, sometimes our patients will withdraw, emotionally too, as they're getting ready to say those goodbyes too. And it's okay to acknowledge that as far as in yourself, that that's not personal. It's just, they're trying to protect themselves as they're kind of wrapping up their end of life and saying goodbye to people. They're moving on maybe to a support team, like maybe hospice, but then they're leaving a team. It's always, as the palliative care nurse practitioner, trying to help people transition from oncology to hospice. It's just they're losing so much. They're not only, looking forward to their end of life, but they're losing this team that has held them so wonderfully over the last, months or years too. So there's a lot of loss in that transition, particularly when people are transitioning from active treatment to hospice or end of life.
Yeah, that's a great point. In some ways, it's certainly a different type of grief, but even our survivors experience that when they transition into more of a long-term maintenance, only see every 6 months, when before it was every other week or something more frequent. And so they experience that loss again, and it's sandwiched in between maybe some more positive feelings of moving on and hopefully thriving forward now that they're done with treatment. But again, grief is not always sad. Sometimes it's just that, like you said, it's a loss. You've lost something that you've had and you've been familiar with, and now that's going away. So that's important to keep in mind for all of our patients, no matter kind of which direction they're headed. One thing that I thought of as you were responding is, I think as nurses, and I speak for myself, of course, is sometimes you're even afraid to ask that question of how are you doing or how are you feeling? because you're afraid about what you're about to crack open, and you're not sure that you are equipped to respond with the right answer. You don't know what to say, or do I have the time to sit with this patient while they experience these emotions, or just you're afraid to kind of poke that bear, I guess. But you want to. It's not that you're uncaring. It's just, again, you're all those other competing priorities and thoughts and feelings. And so sometimes I think the struggle is not knowing what to say or how to say it or how to kind of work through that conversation. And I think sometimes the only thing that you can say is, this stinks. I am sorry. This is terrible. And I've said that myself. We can't always, and you shouldn't always be promising that there's something else we can do. And I think that's a whole different conversation, and we're just trying to find that next line of treatment, when sometimes what we need to do is take a pause and say, this is terrible. And this doesn't look good. And let's all agree that this sucks. Let's just agree before we knee jerk because we're uncomfortable with that. We don't know what to do next, or there is nothing more that we can do from a medical pharmacologic perspective. Maybe just sit with that feeling for a minute, like, this is terrible. This is bad news. And we all feel bad about it. But sometimes I think as nurses, if we don't have that toolbox of communication skills that we know how to talk through some of these difficult conversations, then that's, I think, keeps us from wanting to open that box. So are there tools, are there models of communication that nurses can follow when they're working through these delicate conversations with patients?
That would be a whole nother talk, Jamie. One of the easy ones, which is a little bit like you talked about, just stepping back and taking a breath. So and I'll talk about one of the resources at the end of the thing, but there's this model called PACE model. It's a quick, easy thing to kind of just hold in your heart, pace. I need to pace myself. I need to sit down, make that, nonverbal opening so that people feel like I'm present. So P is the presence. How do you be present? And of course, that is, closing the curtain or just taking a moment. We always think, and this is, Jamie, a little bit what you've alluded to, that we have all these things on the list. And sometimes, 2 minutes of just being present, listening to fearfully, sometimes, what's that box going to open? You can never, I always tell young nurses, you can never say the wrong thing if your face is open and your intent is good. I mean, there's things that you could say better, but as long as you're showing compassion, so that's the C, compassion, really just trying to connect emotionally with them. And then that empathy, not sympathy, but empathy, empathizing with them where they're at. So, I mean, that's a really quick one. And like I said, we could do a whole nother podcast on having these kind of conversations. But I just encourage people as they kind of get fearful to open that door to what is probably going to be a strong emotional response. And emotional isn't always like sad and crying. Sometimes it can be anger or just asking of the why questions, which is, even for myself as a palliative care person is like, those just make my stomach sink sometimes because, the why question is, nobody can answer that for people. And how do you sit with that just distress people often have? So, yeah.
Well, so I think society views oncology nursing as experts in dealing with grief because I think the view is that it's all sad all the time. But is there something that the oncology nursing community as a whole can do to respond to grief and tragedy?
That's a big question. So the nursing community itself is certainly, when I think about that, is help each other learn, you know what I mean? Provide and participate in education regarding coping and grief so that our skill set is as good as it can be. And when I say that lifelong learning is so important as far as we kind of improve our skills, communication skills, what we understand about grief and loss. I think as a community also, we can create opportunities. We can be leader bees or on teams who recommend opening up or creating like a community remembrance or celebration of life. Our small little community every year has Remembrances of the Heart, and we open that up to the community. Not only, so this is an important piece to think about. So it's a reflection on people who have died or passed the year before, but it also is an invitation for all healthcare staff to come and reflect on the losses that they've had cumulatively through the year as well. So that includes, someone who reflects on the grief process, a celebration of hope, music, just again, I think grieving in community, it can be so healing. And if we can open that up to our bigger community, to our emergency staff, down the road, to the small community hospital that I work at, we just, we invite everybody to come participate. I think it is identifying and being able to find places that we can direct people as far as bereavement groups. And I think also, as a community, if you're on a unit or something, what are you going to do as far as set the boundaries or set the rules or set the conversation about what you want to do about memorials? How do you want to do yourself want to attend if it's appropriate? Is it a long-term relationship that you've had, or as a group send flowers, particularly if there's been a loss of a coworker, things like that, as far as responding to grief.
Yeah, I really like that. And I think it goes back to helping to build that culture. So if the team can collectively, again, and whatever the scale of the team can change, it's your unit, it's your hospital, it's your town, creating those shared moments of sort of reflecting and grieving together, that only helps to, I think, build up and enrich that feeling of community and culture that you have with your colleagues. And so again, not everyone maybe will feel like that's what they need to grieve. And that's okay. That's a personal choice, but just giving that opportunity, even if they don't actively participate in whatever the activity might be, being able to see your colleagues, see your team there, it can still feel good to see that. So I think those are some great examples of ways that we can not only share the lessons and the resources and the tools that we've learned having experience in a field where we are accustomed and expecting to have grief, sharing that with the larger group, whatever that larger group might be. Along those lines, obviously, COVID-19 pandemic, it feels like a long time ago, but also feels like it's still here. I'm not sure when that will ever change, but that in itself was a long-standing and intense feeling of panic and fear and grief all wrapped up into one. How do you think the COVID-19 pandemic sort of intensify the grief landscape for all healthcare providers and patients alike?
Well, I think it really brought to light, like in Fast Forward and on steroids, just professional grief and loss. Does that make sense? It's just like, wow, because it wasn't cumulative over months or years. It was cumulative over days to weeks and depending on where, of course, your work setting was and your exposure to that. But in that, I think we all experienced loss of a workforce. Does that make sense? I don't know anybody who is not desperately trying to find nurses for their units, for their clinics, for their hospitals. I mean, we just had a wave of people leave, and that just makes me so sad. I mean, I hope we'll go back and reflect on what we could have done differently, but we were certainly in the middle of a huge crisis. It wasn't just losing patients. I mean, because I was in palliative care, I obviously lost a lot of patients because I also worked like in memory care units and things like that. And so it was just a huge kind of mass loss of my patient census. But the other thing is, it was also, I think, for ourselves, multiple losses, meaning the inability to have funerals, to be with dying patients. We reflect back on that, and it's going to, I think, it still informs people's grief to this day. So when we think about our loss history, I think there's going to be this big blip. And, people left at the time, and people now who are feeling like they're not recovering, or they're feeling like, that they can't recover. I think we all thought that this will and it has died down, and everything is not normalized. I don't know that we'll ever be normal again, but I just think that there's been a lot of reflection as far as people, again, finding different ways to take care of themselves. And sometimes that's leaving the workforce. But I want to bring it back to oncology patients, because I was just distressed. I don't know if anybody else was, but, when you have patients who are coming in for infusions or getting bad news, trying to create an ability to have that news delivered if you can have people in the clinic or in the room, or, they're getting bone marrow transplant. And I mean, there's just all these big things that we know are so important to have family and caregivers as part of the support team that was not allowed. And then also my sadness was that, people who and still are, who live with cancer, are living still in more isolation, in that fearful place of being exposed and trying, we always have told people to avoid people with cold and colds and sickness and everything. But now it's another layer of vigilance. And depending on how they perceive that vigilance, withdrawing from that supportive community because they don't feel safe. And that just makes me really sad as far as how that contributes to their grief of that journey and need for support.
I think living through it and knowing how little we knew at the time. And again, everyone was operating with the best intentions, with the information they had, but you're absolutely right. The limitation of visitors and sort of basically locking down the hospital setting, both inpatient and outpatient, and not allowing visitors with patients during some of those really critical, emotionally fraught, whether it's new diagnosis, that finding out that you have no other lines of therapy left and they're going to talk to you about hospice. I mean, having family there for those conversations seems like unbelievable that we would ever consider not allowing family in. But there were certainly stretches of time where that was strictly enforced. And again, at the time, we were just so unsure. And I don't fault anyone for the decisions that were made, but I think we've already recognized how detrimental that was. And hopefully we use that information moving forward. God forbid there's another pandemic in my lifetime. But again, it's just looking back on that and just what we'll learn and how we'll continue to study that whole period of time. And it will just be interesting to watch. But you're right. It was a very hard time. And I think people who have come through all of that on the other side are still impacted by some of the decisions that we had to make. It just brings home the importance of having support with you during those challenging times. So as we hopefully come into whatever the new normal is in this world we live in now, I think across the board, focusing on our own mental health in general, which includes dealing with sadness and grief, having a plan in place to keep our own inventory of how we're feeling and how we're doing and what needs to change. What can a self-care plan do to help oncology nurses sort of navigate grief and other emotions as they kind of come up through their career?
Well, I guess for one, just acknowledge that this is going to be a reoccurring theme, that this isn't something as a one and done, that this is a process that you're going to continue to revisit. And in recognizing that, I think this allows us to be more proactive and responsive to this emotional part of our job. And so I just so recommend that you put a self-care plan in place ahead of time and be thinking about that just like a care plan for your patients. What are you going to gather for resources? What kind of skills? If you're afraid of holding someone's grief or sadness or having those conversations, where do you get that education? And then I think each time we do any kind of education, we kind of hear something different. What is it, do I need to hear at this point in my career, and what's going to be important as far as looking forward as an oncology nurse in your career, and how do you create sustainability for that?
I think that's more important now than ever. I think we've always maybe known that, but now I think, when you talk about nurses leaving the bedside, because again, it's never a single issue or a single incident, but certainly our own wellness and well-being is wrapped up into that. So what are some things that you would recommend including in a self-care plan?
I am a big proponent of creating rituals or, something that is a good fit for you. It can be something that you do for yourself, just as simple as you're going to laugh at mine. My kind of transition from my really crazy work day and all the emotional stuff that I'm holding, and I have about a 20-minute drive home, is I play, for those of you out there, no offense, I play country music. And I'm not a country music fan, but I play it loud, and it has all these like sad, ridiculous stories and lots of twang. And it just takes me out of my, not anything quiet, just takes me out of my, kind of sad place, reflective world, and gets me hyped up and gets me ready to enter into, my personal life. So kind of how do you shed that day and the grief and the sadness and make some kind of division between your work and personal life? Isn't that silly? But I would recommend creating that.
I think that's great. So often, I love that we're talking about a self-care plan. I hear so much about institutions trying to sort of cram wellness down the throats of nurses. And I mean, again, the intention is right. I appreciate the effort, so I don't mean to make light of it, but sometimes they're going to offer, lavender scented everything and a quiet room to sit in. And sometimes we need to decide, well, what's going to work better for us? Maybe we hate the smell of lavender. So what else is there? So maybe it's country music. Maybe, who knows? Maybe it's a walk with your dog. Maybe it's playing with your children. Maybe it's going out to a movie that you can't wait to see. I mean, the opportunities are endless, but it's personalized. And that, again, we as nurses, we have to take care of ourselves, and we can't not, and again, this is not to say that institutions don't have a piece in making sure that the workplace promotes personal wellness. They certainly have a role in that, but I think we all need to individualize and say, I'm going to take care of myself. And here's what helps me, whether it was a great day or a not so great day, like what's going to help me turn things around so that I can enjoy still the rest of my day left that's not at work, or the days that I'm off from work. You don't want anything seeping over into kind of ruining the rest of your quality of life. And so having those things in place to realize, I'm at a tipping point. What can I do on a regular basis to stay away from that ledge? But also if things become, a crisis, what do you do and what's your plan so that you can reach out for help when you need it? So I love the country music, not my personal favorite, but I support it totally.
So Jamie, you touched on that though. We also need kind of like that card of like, one of those games like call a friend. So, if you are feeling overwhelmed, I really encourage you to just who's going to be that call a friend name? Who is it that you can find as a partner or mentor that you can urgently debrief, if there's just something really tragic that happened in your day, and maybe it's not your family or your partner. I mean, and maybe it is, but sometimes I think, again, that nurse's pain, we hold it and can share it with each other better because, again, just like the families in their grief process, the telling of the story is important. It's important that we can tell it, and then it's also important that we can hear other people's stories and hold those in that container, that sacred space as well. So find that call a friend as well.
I can only speak for my own spouse that he doesn't get it. Because again, sometimes there's just parts you don't want to have to explain. You just want to be able to tell the story or, explain how you're feeling and not have to like define every term and fill in all the gaps. And so finding, as you said, finding that colleague who's in nursing or in healthcare and gets it, just a listening ear sometimes is a huge help. And so that might wrap into how you process your grief regularly, whether it's a unit-based activity or even just, again, having that sort of work bestie where that you can just call and be like, man, today was tough. And they'll get it. Sometimes that's just a huge leap forward in processing the day's events and being ready to wake up the next day and maybe do it again. So, well, this has been great. We've had a wonderful conversation. I feel like we could keep talking for much, much longer. But as we conclude, we get to the end of this episode. There are a few questions that we always like to ask just to, help summarize some of the bigger points that we've talked about. So I'll start those off now. What are some common misconceptions about oncology nurses in coping with grief?
Well, I'll go back to, I think, because it's how oncology nurses are just revered, both personally in their own circles and professionally, that we think that oncology nurses can just take it in stride, that it's part of the job. And of course, cancer patients die. And in this misconception, I think that we miss the opportunity to acknowledge that there is a lot of deep loss and grief that happens in the day-to-day work we do. I also think the other misconception is that we just have to keep going, that we just have to plow through all of that. And I'm giving you permission right now it's okay to take a step back, to reset, to reflect, and give yourself a little place in there to process your grief and not let it build up too long. We can't be intentional and be in that kind of sad, dark place all the time, but I think we can set aside time to process some of that as part of our job. The other misconception I think about coping with grief is that it's always going to be the same. And I think at each part of our professional development and also in our personal lives, we are going to be touched either deeply or be somebody who can, different parts in our lives, just kind of go with the flow. So I wanted to just come back to one more thing I would really encourage you as far as kind of developing a practice is to really look at integrating some kind of mindfulness or meditation or breathing or practice of gratefulness so that you have something that you can always kind of go back to close that loop for yourself when you're trying to kind of get through your day.
I love that. Okay, so what is something about this topic that's not often discussed, but you wish people knew more about?
I am going to go. This isn't a very good summary one, but I just want to introduce real quickly. I think it is about one thing that people don't talk about is taking care of your own or the loss of a coworker. So depending on that relationship, you may or may not go through a grieving process. And even if it wasn't your coworker, how do you create, if it's a coworker's husband or family member, how do we support those people? I think that because a lot of times when we have coworkers who are, experiencing grief or serious illness, that sometimes there's a lot of shifting of roles or responsibilities. They may be on bereavement leave or they may be on sick leave. How are we going to be able to accommodate this both emotionally and just practically sometimes? And then how do we honor them after they're gone? Just this a piece that sometimes we forget that as part of our teams, we are going to experience loss in our own team, whether it's our coworker ourselves or the coworker will have lost or have a family member that they've lost or a loved one.
I love that you brought that up because it is sort of that missing middle piece that we sometimes don't connect that, as a team, we experience collective grief when we have patients that we all know. And at home, we have our own personal stuff, but there's a place those things overlap. And, some of the approaches and things we talked about today will absolutely apply into that scenario as well. But sometimes it's a different approach. So thank you for bringing that up. I love that. Comes back to, again, supporting our coworkers, creating a culture that people want to be at and want to stay with. So it all fits together. What additional training or resources do oncology nurses need to better understand and approach coping with grief?
So when I think about additional training, I think it is going back to that issue around communication about how to respond emotionally, not only to our patients, but to ourselves and our coworkers. So communication, when we talk about additional training, I think learning more about just the nuances of grief itself within ourselves, but also in our healthcare setting. What is it also that we need to understand? Because there's a lot of overlap as far as how we respond and how we respond to patients as well, personally. And then also when we talk about that approach to coping with grief, just recognizing that it does exist as part of our day-to-day professional lives, and how we respond to that is going to impact our ability to stay in nursing and also supporting, again, Jaime, this is a theme we both keep coming back to, creating that supportive environment so that people can have conversation and feel supported, that we can have a place to process the grief that we experience on a day-to-day basis.
Absolutely. And along those same lines, what are some additional resources that providers could look into if they want to learn more?
So if you want to just do a lovely, quick deep dive, the American Nurses Association Foundation, in partnership with ONS and the Hospice and the Social Work Hospice Association, did this great series on dealing with grief. And there's 5 little scenarios of about 5 to 6 minutes. So if you just Google dealing with grief ANA videos, it'll pop right up. And it is a lovely kind of quick and done resource. And then you can share it with your colleagues as well. It touches a lot on a lot of the topics that we have talked on today. If you want to share it with your colleagues and you don't want to do an hour podcast and you want to make sure that they have resources too, you can just hook them to an email and send them out. That was the intention of them. David Kessler, who worked with Elizabeth Kubler-Ross, has a site called grief.com. It has a lot of information on grief. It has some personal grief groups, but they also have a self-care module for professionals that is free, which is lovely. If you've not done the end of life education nursing, the LNEC course, they have a lovely unit, grief and loss. It's so nice to just kind of revisit and learn more just about the basic concepts of that as well. And then ONS has a really nice site around COVID-19, but embedded in there is a lot of great information around grief and loss as well.
Those are all great resources. I'd be remiss if I didn't also mention We have a nurse wellbeing learning library. So in response to learning about grief and how to process that, some of the tools, activities, and other resources that we have added there might help. We have a variety in there because everyone needs something a little different, but I would encourage everyone to check that out and just be aware of what we have tucked in there because, might not need it today, but it might be something that you can turn to when you do have a day that you really could use some extra support.
Perfect. Thank you, Jamie.
Well, Carla, thank you so much for joining us today. Do you have any final comments for our listeners?
So I'd just like to remind you that you're not attached to the patient's outcome as far as their journey in the cancer. You are part of that journey. I think sometimes we just take that on so much, and that adds to some of our grief that we have when we're walking along with patients. Adaptation to loss doesn't also happen at once. And as I said at the beginning, grief is a process, and it's a long-term process that we need to acknowledge. And then also, again, going back to creating that self-care plan so that we can learn to adapt with these ongoing losses that we have on a day-to-day basis. I think we're all going to find our way through the grieving process in our own unique way. But there's a lot of things that we can do as a community to hold each other and support each other in this process. And I just applaud you. Working in oncology is both personally and professionally rewarding. So keep finding ways to keep yourselves on track. We need you out there.
Absolutely, 100%. Well, thank you again, Carla, for sharing all of your thoughts and wisdom with us today. I really appreciate your time.
You're welcome. My pleasure.
Thank you for listening to the Oncology Nursing Podcast. Tell us about your favorite part in this episode by leaving a review wherever you download your podcast. For more resources and information about oncology nursing, visit us at ons.org or voice.ons.org. The ideas and opinions shared in this episode represent those of the guest and not necessarily ONS.